Okay, what's up guys? So back with another video. Today's video we are going to speak about how to progress exercises as well as do a breakdown on two specific exercises, how you can implement them, for what injuries, conditions or sports you may use them for, how to progress them, how to regress them, which muscles are involved and which movements are involved. So before we get into the exercises themselves, we're just going to speak about how you as a practitioner or even as someone that trains in the gym can progress your exercises and know that you're making linear progression. So the way we do this is essentially when you start with your exercises, you follow a set plan determined by reps and sets. So when we're going to look at progression specifically, usually in a beginner sense, we always start with the basic principle of 2 sets and 8 reps. So you do 2 sets of 8 reps, and for rehab purposes, I'm going to start it off as body weight, so I'm not going to include any weight, just so that we can set the foundation for the basic principle. So if you do 2 sets of 8 reps, your output is going to be a total of 16 reps, and that is your stimulus and your output. Then when you are to progress from this, we're starting at week 1, and then if you go to week 2, the easiest way to progress this is starting at the reps first. So you're still going to do 2 sets, but instead of 8 reps, now you move on to 10 reps. And that is going to give you a total of 20 reps, which is plus 4 in your stimulus and your output. Okay. Then you can keep on doing this. So week 3, you do 2 sets, 12 reps, and you're going to have 24 as your output, which is plus 4 stimulus and output. And then once you've covered 2 sets, 8 reps, 10 reps, 12 reps, if your goal is mainly hypertrophy and muscle building, as it is in exercise rehabilitation as well as resistance training in the gym, you would like to stay between that 8 to 12 rep range, because it has been proven in research studies to be the most effective rep range for muscle hypertrophy. So considering that you want to stay there, you're not going to up the reps again, but rather you're going to go to upping the sets now. So for week 4, you're going to go to 3 sets, and then you're going to do 8 reps again. And now you're stuck with 24 again as your output or your stimulus. Now the reason why 3 sets of 8 reps could be more beneficial than 2 sets of 12 reps is because of that prolonged state of rest in between your sets. Your output in your 3 sets is going to be higher than the 12 reps, because in the 12 rep range, you're starting to fatigue between rep 10 and rep 12 in more or less that range. Whereas if you break it down into a smaller number, your output is going to be much higher at rep 8 than it would be at rep 10 in set number 2. So this 24, even though it is the same as the 24 in week 3, your stimulus might change dependent on your output. Because your output and your contractile force and the mechanical tension that you deliver in those 8 reps are higher than the 12 reps, the 3 sets of 8 might be more beneficial than the 2 sets of 12, depending on all the variable factors that are included in muscle hypertrophy, having time under tension, mechanical tension, and having your rate of perceived exertion. Taking all of these into account, most generally, you can interchange between these two. But if you are failing and your reps in reserve is 0 at rep 8, but your reps in reserve at 12 is still 2 or 3, then the 3 sets of 8 is going to be more beneficial. But conversely, if you're doing 2 sets of 12 and you feel more fatigued after the 12 reps instead of the 8, then your output and your stimulus will be more in your 2 sets of 12. But because this is a body weight exercise and it is non-weighted, it is not generally taken to failure. And when you do bodyweight exercises, then having that rest and being able to have more fibers contracting in the 8 repetitions than in the 12 repetitions, it could be more beneficial for you. Now again, this is opinion based. You can make your own decisions based on what information you have gathered and research that you have done. I prefer the 3 sets of 8 reps, especially in weighted and non-weighted scenarios. It gives the patient more time to rest during the performance of the exercises, and it allows for optimal contractile force. And then we go into week 5, which is going to follow the same progression, because week 5 is going to be 3 sets of 10, which is going to give you 30, and that's plus 6 in stimulus and output. And then week 7, you're going to have 3 of 12, equaling 36, which is increase in stimulus and output. Now, staying for hypertrophy reasons, in that 8 to 12 rep range, increasing your sets and linearly increasing the amount of hypertrophy that you can have, while every week making sure that you are either upping in your stimulus or your output, whether it be with intensity reps or sets, just making sure that there is progression happening throughout the weeks. Now, because this is body weight, it is the more simplified version. Once you add weight, there are other factors that come into play that we'll speak about now, that you can take a look at to make sure that you are progressing. So when it comes to weighted exercises, we're going to use the same principle of, in week 1, you have 2 sets of 8 reps, and you're going to say 2 times 8 is 16 in total. Then we add the weight component. For this case, we're going to say it's 5 kgs, which is going to give you a total of 80 kgs, which is your force output. Now, progressing from week 1 to week 2, we're going to use the same method we used before, 2 times 10 to up the reps, 2 reps extra, which is going to give you 20, and 20 times the same weight, 5, is going to give you 100 kgs of force output, which is plus 20 kgs, which is going to be a new stimulus and objective quantifiable measurement of ensuring there is stimulus happening for muscle hypertrophy. Now, if we're going to take a look at week 3 and week 4, we're going to see more or less the same trend that we saw before. So if we take 2 times 12, which is 24, and we say 10 kilos, we are going to get a force output of 240 kilos. And if we take week 4 of 3 times 8, which is also 24, times by 10 kilos, your force output is going to remain exactly the same. Now, in terms of objective data, this is not what you want to see. You don't want to see the numbers staying the same for an extended period of time. And just as a reference, remember your patient or you in yourself when doing resistance training, you are not going to see weekly increase unless you are a new person coming into the gym for the first time, having that new stimulus. You're going to see rapid growth. But as a trained individual, this is not as applicable. It's not always going to be week in, week out that you see numbers going up. It is rather going to be in the span of week 1 to week 6 or week 6 to week 12 that you're going to see minor adjustments in the way that your force output increases. But now, because these numbers stay the same, and even though you don't want to see them stay the same, you can use that same method as before, keeping rate of perceived exertion and reps in reserve in mind to see which one of these two is going to benefit you or the patient the most. Which one of them do they experience the most force output in terms, not force output in terms of objective data, but where are they most fatigued? Where do they feel like they are feeling the exercise more? Do they feel like the 2 times 12 is leaving them more fatigued, or the 3 times 8? Do they feel that they get more benefit from the rest for the last set? So even though those two stay the same, you can still use your discretion to see which one benefits more. But now, if we're going to take a look at the weight factor specifically, you can use the 2 times 8 rep range to still make your patient have a higher force output than the 3 times 8 or 3 times 12. So if we're going to say in week 5, your patient did 2 sets of 8 reps, but now, which is going to give you 16, now you've placed the weight at 40 kgs, for instance. Are we going to make it 40? No, we're going to make it 20. If we're going to make it 20 kgs, their force output is going to be 320 kgs. Now, even though your sets and reps for week 5 are less than in week 4, because your weight is significantly higher, the force output in your stimulus is much higher than it would have been in week 4. There's at least an 80% kilogram difference in force output from week 4 to week 5. So playing around with these numbers, you have 3 different ways that you can progress your patient. Either increase sets, increase reps, or increase weight. And as easy and simple as that sounds, if you don't use the math effectively, then your numbers are not going to be what you want them to be. This is not a guessing game. This is not something that you go off of that you think you're getting better. Especially if you're a healthcare professional, you're supposed to know that your patient is progressing, especially if they are in an orthopedic setting, that their force output is continuously increasing and you're seeing that length. I am going to break it up into different components. So we're going to look at the exercise itself, we're going to look at the movements involved, we're going to look at the muscles involved, we're going to look at what injuries, conditions, or sport you can use them for, and then what progression or regression looks like. So we're going to start with probably the most popular exercise in exercise rehabilitation, not primarily my favorite, but we're going to start with the pelvic lift. So in the pelvic lift, what we have is your hip extension, and we have trunk or spinal stability, and then we have some portion of knee flexion, knee extension, very minimal. Those are the main things that happen. Along with that, there is a lot of pelvic floor strengthening, especially if you have TA activation. But we're going to get into that with the muscles. So for the muscles, if we look at hip extension, we are looking primarily at glute max. Your trunk stability, we're going to look at your lower abdominals as well as your transverse abdominis. Then we're also going to look at, for trunk and spinal stability, your erector spinae muscles in your lower back. Knee flexion extension, you're going to look more at hamstrings than you do at your quads because they have more activation. So those are the movements and those are the muscles. Then when we look at injuries and conditions, this can be used for, we have pre and post natal, which is always a good exercise to have for those patients. We're going to look at your knee injuries such as your ACL or your meniscus tear. We're also going to look at things such as hip impingement. We're going to look at lumbago, which is mechanical lower back pain. And then we can also look at something like SIJ dysfunction. Then for specific sports, these can be used for sprinters and marathon runners. As a means of getting them to activate their glutes and hamstrings properly. There are various other sports that you can use them for. Because the pelvic lift's primary function is for your glute max and as well as your lower back and pelvic floor and stuff like that, It is because your glute max, why did I write glute bridge? Glute max. Because your glute max is your primary muscle for hip extension, and the biomechanics of running implies that your glute max and your hip extension is a primary mover. Doing pelvic lifts with them can help them to get a better mind muscle connection, to see how that they can effectively contract their glute max muscle and optimize their running posture. Then in terms of progression and regression, when we're going to look at progression, you're starting off with a pelvic lift as normal. Then you can do, if you want more hamstring involvement, you can do them on their heels, doing a pelvic lift on the heels specifically to get more hamstring involvement. Then you can do a single leg pelvic bridge, which is a progression from the normal. You can do a pelvic bridge with hip adduction isometric, and then you can also do pelvic bridge with hip adduction isometric single leg. Then final one, you can do an elevated pelvic bridge and a single leg elevated pelvic bridge. Those are all the progressions. Then when we look in terms of regression, we're going to look at the pelvic tilt as well as pressure, air, biofeedback, TA activation. Now I know these are a lot of words. I'm going to put pictures up on the screen of what each exercise looks like so that you can have an idea, especially the pressure, air, biofeedback. That is something new that people don't really know of, but doing pelvic tilts and doing TA activation will effectively lead you into a space where you can do an effective pelvic lift. So that's exercise number 1. We're going to move on from pelvic lifts and we're going to move into a very basic movement, which most people think is very basic, but in my opinion is very complex and involves a lot of different portions. We are going to take a look at the step up. So in the step up, the movements that are involved is initial hip flexion. Don't know what fell, goes on the cap. Initial hip flexion to get your leg up onto the box that you're stepping up off of, which is going to be one joint hip flexion because the knee is bent. One joint. Then we are going to have hip extension and knee extension happening more or less at the same time when you perform the movement. Other accessory stuff is going to be, again, spinal and trunk stability, but those are more accessory. You can, if we're going to go into the niches of it all, you're also going to look at adductors versus adductors of the hip for knee stability, as well as your peroneals and tib ant for ankle stability. But for now, we're going to look at the primary muscles involved. So for hip flexion, your initial is going to be your iliopsoas muscle, which is your one joint. Then for hip extension, again, glute max and hamstrings. For knee extension, we're going to look at your rectus femoris and your vasti group as your quadriceps, and then trunk stability, your internal, external obliques, and TA. Now I know rectus femoris has somewhat involvement in the hip flexion portion as well as when you do, if you take a look at concentric versus eccentric and lengthening versus shortening, when you are doing that initial hip flexion movement to get your leg up onto the box, then moving into knee extension to get your leg straight, your rectus femoris is going to be involved from start to finish in the movement. That is primarily why when you do a step up, the two main muscles that are going to suffer under DONS, which is delayed onset muscle soreness, is going to be your glutes and your rectus femoris. Those are the two muscles that you will feel the most. Then when we look at injuries and conditions that you can use this for, a very good one is hip replacements. Then you're also going to look at everything in the knee: ACL, PCL, MCL, LCL, you're going to look at your hip impingements. Then I'm not going to say that name, or I will try, but it is effectively necrosis of the femur head. Necrosis of the femur head, where there is lack of blood flow to the femur, and there's breakdown of bone tissue. You can use that for that as a mechanism of bone loading as well. Then you can also do for what else can we do this for? We've got hip replacements, knee, hip impingements, necrosis of the femur head. I think those are fine for now. Sports, again, we're going to look at runners, sprinters, and marathon runners. Now, in terms of whether it's more beneficial for sprinters than marathon runners, if you're going to do a plyometric step up, I would say it is more for that type 2 muscle fiber, which is ballistic. If you're going to do more of an endurance, longer sets, longer reps, then you can modify it to be for a marathon runner. In terms of progression versus regression, your progression, if you're going to start with a body weight step up, you are going to increase the weight, like we spoke about before, increasing weight, increasing force output, which means increasing stimulus. So you increase the weight, you can also increase the volume, but then when we are looking at the exercise itself, when you increase the weight, you add dumbbells, or you add a barbell, or you add ankle weights. Another progression would be moving on to a plyometric step up, and then increasing the height of the box is a method of progressing. If you start a step up on a step and then progress to a box which is 40 inches, then go 60 inches or whatever it might be, whether you use meters or inches, you increase the height, which is also going to be increased distance, increased time that the patient has to contract the muscle, and increased forced output, increased time under tension. That is a method of progressing. In terms of regression, you are then going to decrease the height of the step up. Then you can also take them back to the basic terminal knee extension, which is going to help them with the contractility of their quadriceps muscles. So doing terminal knee extension, and then also doing things such as basic knee extension exercises unilateral with the TheraBand to build up strength in the quadriceps. So doing knee extension with the TheraBand, and you're basically going to take these movements that you've done before, and instead of making them into a compound movement, you're going to break these up into individual segments, strengthening one specific group of muscles at a time until all of these muscles can sustain the patient to do a step up in itself. So once you have your hip flexion, one joint, which you can do with a TheraBand as well, or an ankle weight, hip extension you can do with a cable or you can do with a TheraBand, knee extension with a machine or with a TheraBand, and trunk stability, which is an accessory, but you can also do a Pallof rotation or Pallof press with that. Once you've increased and have your patient in that 3 sets of 12 reps with an effective weight or TheraBand, that you can see that they are strong enough to sustain a body weight step up, contracting all of these muscles, then you can take them into the progressed version, which is going to be your step up. So your primary regresses are going to be the movements that are compiled in the step up movement in itself. Okay, so that was the breakdown for 2 specific muscle movements, how you use them for exercise prescription, which injuries, conditions you can use them for, what muscles are involved, what movements are involved, as well as how you progress in sets, reps, and weight to ensure you and yourself as resistance training is making progress, or your patient is making progress, and you can eventually have them be cleared. Thank you for joining me today, and I hope you have a lovely day further.